All right, good morning everybody. I think it's nice to start now without much delay. This session is a joint GHA ESC session, and I'm joined by ESC President Professor Jeroen Bax and myself, Mohammed Zubayd. We have had a great deal of collaboration from the ESC over the past few years. And since the inception of GHA, the ESC has been a driving force behind a lot of our activities, both locally in the region and whenever we're at the ESC meetings. So we're very pleased to be with you here today, Professor Bax. And our first speaker is Professor Pepe Zamorano. And I've had the fortune of working with Professor Zamorano very closely. He's has a lot to do with imaging, and he's the president of the European Association of Echocardiography, chair of the ESC guidelines, and chair of the Global Affairs. And because of the Global Affairs, we've had a lot of contact and collaboration with him in person and with the ESC. So without much delay, we'll start with Professor Zamorano, who will present us the new ESC guidelines on valve disease. So Pepe.
Yes, thank you for these kind words. May I have my first slide, please? Yeah. So I'm extremely delighted on behalf of the European Society of Cardiology of being here with you. I really enjoyed yesterday the meeting, and I hope that during the next minutes I can share with you how we do understand this complex problem of valve disease, and really I'm going to try to focus in the tips how to manage the different diseases. So first, let me try to clarify why we do believe that the ESC guidelines helps. And really help you because it's a very comprehensive tool to help in your daily clinical practice. So we have a lot of materials there. It's not only the full text. We have the slides, and you can download that from the web. We have the pocket guidelines. We have all these summary cards just giving the real tips of what to do. Well, let me remind you the classification that we use. Well, don't forget that class 1 and class 3 are the real relevant things. This means class 1, you should do that. It's really recommended, and you cannot avoid not doing that. And class 3, this means that you should not do it. So both terms implies call your lawyer if you don't do that, or if you do that and it's a class 3. And then class 2A means that it should be considered, and class 2B may be considered. So class 2 is a debate. So also, well, don't forget that we have level of evidence. A implies is data derived from multiple randomized clinical trials. Then we have level C, which is consensus. But don't forget is consensus of top experts. And level B is data derived from a single randomized clinical trial or a large non-randomized study. So I agree with you that in the valve we have a lot of class C. So we have a lot of consensus. So for example, we will send to surgery a patient with severe aortic stenosis, and it's a class C because there is no randomized clinical trial on that. But it's really a consensus. As appeared years ago, I remember that in an editorial, a class C will be just jumping from an aeroplane with a parachute or without a parachute. It's a class 1C, and it really adds also value. Well, the guideline in valve is addressing at the beginning, so what are the main issues that you should consider while treating a patient with heart valve disease? So it's not only how severe is the disease, it's also the etiology, it's also if the patient has symptoms, and if the symptoms, you need to be sure that are related to that specific valve disease. Well, also, don't forget about the estimation of risk of a given procedure, and it's also important the estimation of risk of that procedure in your own hospital. So this makes a complete picture of the patient, and this is why the heart team, the heart valve team, is really highlighted in this guideline, because it's your heart valve team. It's your heart valve team in your hospital with your results, with your team, with your people. So you need to analyze your own results there. How to evaluate the valve disease is also taken into account in the guideline. Here in the aortic regurgitation, you need to look, and in all the valves, to the morphology, to the color flow, to all the echo signs that will make you the diagnosis of severe or non-severe. And in aortic regurgitation, vena contracta is highlighted, especially in the guidelines, and also the pressure half time below 200 is a sign of severe aortic regurgitation. Well, the quantitative echo is also highlighted, so the effective regurgitant orifice more than 30, the regurgitant volume more than 60. I think that all those signs makes the picture much more comprehensive in assessing the severity. Mitral regurgitation, not so easy sometimes to quantify. Again, morphology, the color flow pattern, the CV Doppler signal of the regurgitant jet are traditional signs of severity. And again, here the vena contracta seems to be very useful in quantifying the severity of mitral regurgitation. Well, don't forget that when we speak about mitral regurgitation, we should differentiate, and this applies for the diagnosis, but also for the treatment in primary or secondary mitral regurgitation. And this slide is quite relevant because the cutoff values of the severity for mitral regurgitation are different than the American guidelines. So we do believe that the primary mitral regurgitation more than 40 is severe, more than 60 regurgitant volume is severe, and in the secondary the value should be more than 20 and more than 30 for the regurgitant volume. So then, how to manage? Well, here I will start with aortic regurgitation. One of the things that is really relevant is to measure and quantify the aorta. So it's different if we have a patient with severe aortic root dilatation or not. If a patient has severe aortic root dilatation, this patient is going to be to surgery with significant aortic regurgitation. You need to repair both. Well, what happens if the patient, now we follow the path in the left part of the screen, if you have non-significant aortic root dilatation, but you have severe aortic regurgitation, symptomatic implies surgery. So in other words, you need to clearly know that symptomatic severe aortic regurgitation implies surgery, that if you have asymptomatic severe aortic regurgitation with an ejection fraction that is less than 50% implies surgery, and then you need to really look to the aortic root. What means looking to aortic root? Well, if the patient has a Marfan disease, then you will need to send this patient to surgery if the aortic root is more than 5 centimeters. There is an exception here, and here you had 2A indication. If the patient has a Marfan syndrome with genetic genes that are prone to more aortic rupture, and you have here the genes that has been related to this rupture, and therefore, if you have these genes and aortic root dilatation more than 4.5 centimeters, there is a 2A indication for surgery. Well, what happens if you have a patient with bicuspid aortic valve? Again, this has been even recently discussed. but the ESC guidelines with a 2A indication suggest surgery with more than 5 centimeters of aortic dilatation. In the rest of the patient, so you have a patient with non-disease, we have a tricuspid valve, then it's more than 55 millimeters for surgery with a 2A indication. Well, let us move to severe aortic stenosis. And here in this specific patient, the heart team really plays a role. Well, the indication for surgery has not really changed. What has changed in the guideline is the approach between TAVI or aortic valve replacement by the surgeons. I think that no doubt that if you have symptomatic aortic stenosis, something needs to be done. And if you remember correctly the past guideline of the valve, if the patient has a severe or very high risk for surgery, you can consider TAVI as an alternative. As you have seen yesterday in a nice session, the concept of intermediate risk really jumped in the arena in the last years, and for sure also in the guidelines. So what we should do here? Well, here, in the same way as in the past guideline, high risk for surgery implies TAVI is an option. What happens in the asymptomatic patient with severe aortic stenosis? Well, I think that it's clear also with a class 1 indication that the surgery is indicated in asymptomatic patients with severe aortic stenosis and systolic LV dysfunction. That means ejection fraction below 50%. And also, don't forget that if the patient has an abnormal exercise test, then this means that it's not really asymptomatic. This patient should be also considered for surgery. The heart team is crucial here. Why is crucial? Because in patients that are older than 75 years old, and this is new, in the previous version was older than 85, the 75-year-old, this time in the new guideline, is the cutoff age for considering TAVI. So a patient with 75-year-old, intermediate risk, it could be, according to the heart team decision, sent to surgery, class 1, but also to TAVI. And what really matters? Who will take the decision? The decision should be taken by the heart team. So then, in the guideline, because the heart team is not to discover who is the macho alpha in the team in the hospital, it's really to discuss the patient and try to go to a conclusion just which is the technique that benefit most for the patient. So in this guideline, it really applies like a checklist. So what favors TAVI and what favors surgery? As you can see here, frailty favors TAVI as expected, endocarditis, suspicion of endocarditis as expected surgery, but it's not only these specific conditions, it's also the anatomical and technical aspects. So I think that also the size really matters, the presence of thrombus, the porcelain aorta, if the patient is going to have also CABG, I think this is really relevant to consider. Also, don't forget if you have added other valve abnormalities, you will need to consider surgery in those cases. So the new thing is we move from severe risk to intermediate risk, we move from 85-year-old to 75-year-old. Those things you need to consider before making the final decision. What happens with mitral regurgitation? Again, here it is really important to define if it is primary mitral regurgitation or secondary. I will start focusing in the primary mitral regurgitation. And if the patient is symptomatic and you have an ejection fraction that is more than 30%, then this patient should be sent to the operating room. And obviously, repair is the preferred method. I think that the critical decision here is what to do with a patient with very low ejection fraction, less than 30%, here the surgical risk is extremely high. So you will need to start with medical therapy. If it is really refractory, then you need to really try to think if it's going to be a possible for repair, and here then go to surgery. But here the results are not so good. What happens if the patient has a primary severe mitral regurgitation and is asymptomatic? Here imaging plays a critical role. You need to see the LV volumes and the LV function. And the cutoff values were same as in the past. You see that if the patient is asymptomatic and you have a depressed ejection fraction, that is here ejection fraction less than 60%. Remember, a patient with ejection fraction 50% and severe mitral regurgitation, the LV is already suffering. So we need to do something there. Or is enlarged, is dilated, and systolic diameter more than 45, then surgery, repair if possible, is recommended. So what are the class 1 indication? First, you need to push your surgeons, your hospital, try to repair. And this is not easy. You need a volume for repair valves to achieve results. Well, surgery is indicated in patients with LV function, ejection fraction more than 30, class 1, and is indicated even if you are asymptomatic but you have LV dysfunction, as I said before. So what happens here as a 2A indication, I think that the characteristics of the valve plays a role here. So don't forget that a secondary mitral regurgitation is different. And here we only have one class indication, class 1, which is patients with secondary chronic severe mitral regurgitation that are going to be intervened due to CABG. Then here, class 1, you need to do something in the mitral valve. Well, what happens with the clip before moving to mitral stenosis? The clip for mitral clip is still a class 2. It's not a class 1. We're waiting for more trials, and I think that the clip is an ongoing research, the mitral clip, and this is the reason. I got a question also yesterday from one colleague, and it's not a class 1 indication. What happened with the mitral stenosis? Here, not really change. Severe mitral stenosis or significant mitral stenosis, mitral valve area less than 1.5, then you will need to try to do a mitral valvuloplasty and do surgery if a mitral valvuloplasty cannot be performed. So you need to intervene with percutaneous mitral valvuloplasty in symptomatic patients without any unfavorable anatomic characteristics. So what to do there? Send to the cath lab. If not possible, then send to surgery. So when in any symptomatic patient? Well, then what happens with tricuspid regurgitation? I think that tricuspid regurgitation finally has not really changed in this guideline. Surgery is indicated in patients with severe primary tricuspid regurgitation undergoing left-sided valve surgery, as usually. Nothing had happened here, and in secondary tricuspid regurgitation is indicated in patients with severe secondary tricuspid regurgitation undergoing the left surgery. Nothing is said about percutaneous treatment because it was too early. This is an ongoing research. Many studies are ongoing now, and this will be a pending issue for the next valve guideline. So the figure for the tricuspid regurgitation, the question here is, are you going to send this patient for left-sided valve surgery? Yes. Then if it is severe primary or secondary TR, you need to do a tricuspid valve repair or replacement if not, it's not possible. So in summary, what is my main conclusion of this message? Well, the ESC guidelines are very, very solid. the process of writing the guideline is really based on the evidence. If it is not possible to find evidence because there is no research there, especially in the valve, you have a consensus. But the consensus is done, I want to reinforce that, of really, really top experts. After that, we have a blind review process. Even the writers, the task force, they don't know who are the reviewers, and in the opposite way also. So it's reviewed. At the end of the day, more than 100 people just have an impact in the guideline. They are extremely solid, and the conclusions in this valve is the need, the ESC really highlight the need for the heart valve team. It's a matter of discussion, each patient on your own hospital, your own result. And it's really, the guideline has evolved. You have seen the TAVI, we have really evolved according to the latest evidence. Thank you very much.
Great. Are we taking questions? Yeah, let's take questions. So Professor Zambrano finished a minute and a half earlier. Dr. Mu'taz, yes.
Thank you for this nice call, nice presentation. My question is regarding the indication of tricuspid valve regurgitation surgery. According to the new guidelines, that the only class 1 indication is when we have indication to open for the left side. Is that valid also for some special situations like Epstein anomaly and endocarditis related tricuspid regurg? Thank you.
No, I think that that slide moved too fast. And the indication was we need in the tricuspid valve to separate primary and secondary tricuspid regurgitation. So let us imagine that a patient has a mitral stenosis that is moderate. You are not going to do nothing, but the patient has severe tricuspid regurgitation. Then here is not a class 1. So in case of that, if you are going to send the patient for left-sided valve repair, replacement, whatever, you need to do something in tricuspid valve. Let us now move to the patient with primary tricuspid regurgitation. Here the indication is different. If you have an endocarditis in the right side, well, then you don't need to send the patient always to surgery. You treat the patient and you see, but you enter in the endocarditis guideline. Let us imagine a patient with endocarditis, pulmonary embolism, negative blood cultures, not responding to antibiotics, then you may consider that. So the indication from left-sided applies to the secondary tricuspid regurgitation.
Pepe, I wasn't sure if you addressed, there's a question? Yes, Victor, priority is for the audience, not for the co-chairs. That's good.
Thanks for the nice presentation. I'm Dr. Hassan Khoja, cardiologist. I want to ask about the level of the indication for the asymptomatic aortic valve regurgitation with normal ejection fraction according to the measurements of the left ventricle. What's the level of the indication here?
Well, here what you need to look is in the aortic root. So you have two possibilities. You have an aortic root dilatation, patient with tricuspid valve, aortic valve severe, and you have a tricuspid valve and an aortic root dilatation of 6 centimeters. This patient needs to go to surgery and repair both, the root and the valve. If the patient has a normal aortic root, then it depends. If the patient is asymptomatic, first be sure it's asymptomatic. Second, look to the ventricle. If the ventricle is dilated, you need to send the patient to surgery, and if the patient has also reduced ejection fraction, then you need to consider surgery. In any case, all the slides you can download also with all the specific numbers from the ESC web, and you can take also all my slides because sometimes...
Yes, is there a cutoff measurement for the diastolic measurement of the ventricle or systolic?
Yeah.
Is more than 65 millimeters or...
Is systolic is the main determinant, and you need to go to 45 millimeters.
Great, thank you very much, Pepe. Thank you.
Well, then we move on to the next talk. And it's my pleasure to introduce to you Dr. Ali Bushiri. And he's going to discuss with us about remote monitoring of cardiovascular implantable electronic devices. So he has been trained fully in cardiac electrophysiology, one of the subspecialties that's very high on the ranking list in cardiology. He's working in Kuwait at the Disaba Amahat Cardiac Center, and he has trained basically everything in the United States at the George Washington University. I think the topic of pacemakers, ICDs, ablations is very actual because we see in cardiology that a big shift is taking place towards more and more procedural treatment. More and more patients coming just for procedures, and a big part is in the electrophysiology world. And with that comes, if you implant all the devices, that you need to have your department ready for remote monitoring. And I think that's your topic, and I look forward to your talk.
Okay, thank you very much. I'd just like to thank the organizing committee for inviting me to talk, and I apologize for the change in topic, but as an electrophysiologist, I doubt you want to hear me talk about valvular disease. So in the past few days, most of the speakers did a great job covering most aspects of cardiac electrophysiology, but I feel an area that doesn't get as much attention but is arguably just as important is remote monitoring of devices that we implant. So for those unfamiliar with the term CIED, it essentially encompasses pacemakers, defibrillators, and implantable loop recorders. And by definition, it's anything we implant in the heart with purposes of monitoring and or managing the electrical activity of the heart. So why do we monitor these devices? Obviously, you want to protect your investment. We implant a device, we need to make sure the leads are working, that the battery is working fine, that there isn't any premature battery depletion or unexpected behavior, and no evidence of any lead fracture. In addition, when we interrogate these devices, we obtain a lot more information. We can tell what percentage of pacing the patient is receiving, and this is obviously very important in a patient who has a CRT device because you want to make sure they're making the most out of that device. It also gives you the ability to reprogram the device, minimize output settings in order to prolong the battery life as much as possible. In addition to that, we can obtain any arrhythmic episodes detected by the device, and this is obviously very important in patients who have an ICD implanted because that's the main purpose of that device, to detect and protect from these arrhythmias. And any therapies that are given by the device, we can assess, review the EGMs, determine if this was an inappropriate or appropriate therapy. And finally, there are much more data that you can obtain from a device, including other physiologic parameters. And one that's gotten a lot of attention is intrathoracic impedance. And essentially what this is it checks how easy electricity conducts from the endocardial lead to the generator, with the lung obviously being in between. And the theory is if you have a lot of fluid in your heart, in your lung, electricity travels easier, impedance drops. And using this rationale, the device will try to assess what the fluid status in the body is, and this can help determine if the patient is tipping over into congestive heart failure. These are just some quick examples. For those unfamiliar with device interrogation, the top of the screen you can see markers that tell you what the device thinks it's seeing, and at the bottom are actual electrograms from the individual leads. And this is a patient who had a CRT-D device who came complaining of recurrent shocks. And looking at the RV lead, which is the middle one in the bottom, you can see these high-frequency signals, which don't look physiologic, but the device being programmed what it is programmed to do sees that there are these high-rate episodes that it classifies as VFib. But on further inspection, if you look at the LV lead, you can see that conduction persists, and you would assume if this was true VFib, it would affect both chambers. So this was in fact a lead fracture that was leading to inappropriate shocks, and this is something we can readily assess when a patient comes and has his device checked, or if it's checked remotely. This is another patient who came for evaluation who has a dual chamber pacemaker for complete heart block. She was asymptomatic, everything was working fine, but the device detected these episodes of high atrial high activity. And you can see what starts as an asensed V-paced rhythm, the atrial rate speeds up and quickly degenerates into AFib. And this would have otherwise gone undiagnosed unless the patient had their device checked, since she was completely asymptomatic. And finally, just a quick slide on thoracic and intrathoracic impedance. You can see that on the bottom part of the graph, a drop in your intrathoracic impedance that correlates with what the device thinks is an increase in volume status, and this is supposed to help guide clinical decisions. However, it's not very specific. So the next question is, we know we need to check these devices, but how frequently should we check them? And the HRS set forth these guidelines, which have pretty much stayed the same since 2008. All devices should be checked within the first 72 hours prior to discharge, just to make sure that there has been no acute lead dislodgement and all the leads are working fine. And then within 12 weeks, another in-person evaluation should happen just to make sure the wound's healed okay and that there's no evidence of any lead or battery malfunction. After that, during the stable period of follow-up, it's pretty much left up to the physician and patient. However, pacemakers should be checked at least once a year and defibrillators twice a year. And these should become more frequent as the battery approaches end of life. The methods of monitoring in the past, pretty much our go-to was in-person evaluation. The patient comes, and this still pretty much is the most common method. They come to the clinic, we check their device, and this also allows a clinical assessment of the patient. You can check their vitals, you can examine them, and it allows you to program the device and assess real-time changes in the patient when you change any settings and see how they tolerate them. However, this obviously relies on the patient coming to clinic and showing up. And as we know, not all patients are great at following up. And one study showed that up to 25% of patients did not follow up within 1 year of implanting a device. Which leads us to remote methods of evaluating these devices. There has been a lot of progress, and I will briefly go over the history of it, but obviously the implementation of remote evaluation allows you to check on these patients without them having to physically come into the office. Transtelephonic monitoring, or TTM, was a very interesting technology that was introduced in the 1970s. This was only applicable to pacemakers, but it gave you a brief snapshot of the pacemaker's activity. Using an analog landline, the patient would connect themselves and electrocardiographic information would be converted into sound signals, then later decoded on the other side to a receiving physician, and it would give them information on sensing, capture, battery life, as well as a real-time ECG. This was very helpful back in the day, but there were limitations. Like I said, it was only applicable to pacemakers. It does not give you any information on any stored events within the device. You can't retrieve those through TTM. And obviously, it requires scheduling between the patient and a receiving physician or allied health professional who would interpret the data. And this is a brief picture just explaining what I just said. Then in the 1990s, remote interrogation was introduced. And essentially, this is the equivalent of an inpatient evaluation done at home. The patient is given a transceiver, which they set up at home. They use WAN-based RF technology, similar to what we use with our own devices in clinic, and they basically put it over their device. It transmits information to the transceiver, and then the transceiver would send this information via a landline or cellular line to a central repository, where it is stored and made available to the physician via a secure website. Again, this requires the patient to physically go home and interrogate their device. And then, in 2001, an automatic platform was introduced. Now, when I say remote monitoring, it pretty much covers everything I'm talking about, but specifically when we say remote monitoring, it is referring to this automatic method of transmission between the patient's device and their transceiver. And here the patient doesn't really need to do anything except come into close proximity with the transceiver. And usually we tell them, put it somewhere in your house where you're usually in once a day, which is their bedroom. And whenever they are in close proximity to the device, it automatically makes a connection with the transceiver, and it is set to send transmissions at a certain frequency which the physician determines, usually every 2 to 4 weeks. However, in addition to that, anytime an alert event is detected by the device, such as any changes in lead impedance, any VTAC or VFib, it will automatically transmit that too, regardless of the set frequencies. And obviously the patient can also transmit if they're feeling anything abnormal. And so obviously there were a lot of perceived benefits of implementing remote monitoring. One of them being less face-to-face visits. A lot of times we see these patients in clinic and we don't really do anything. We just tell them everything's fine, we'll see you in 3 to 6 months. So by reducing these face-to-face visits, you allow physicians to free up their schedule, see more patients, and the patients obviously don't have to take time off work, come to clinic, see the doctor for something that is pretty much uneventful. But in addition to that, it may allow for earlier detection of issues. Since we are relying on our follow-up to see the patient and see if anything's gone wrong, if there is automatic transmission, we will pretty much immediately be notified if there is an issue with a device or the patient. And so back to this patient who came with inappropriate shocks, if he had enrolled in remote monitoring, there is a good chance we would have picked this up before the device started shocking him inappropriately, and this could have been averted. And this obviously has very big clinical consequences in that patient. So the next question obviously is, we assume there's a benefit, but is there any data? At the time of 2008, when the first consensus statement came out, a lot of this technology was new. There wasn't a lot of prospective data. But since then, and at the time of the 2015 HRS consensus statement, there has been an overwhelming amount of data in support of remote monitoring. And so the answer is yes. I will not go over all the trials, but I will briefly touch on a few that I think hit at the main points. The TRUST trial, which came out in 2010, enrolled just over 1,000 patients with ICDs and compared scheduled monitoring to remote monitoring. And it found a significant reduction in hospital evaluations by up to 50%, which you would expect, in addition to reducing the time to detecting any arrhythmic events from a median of over 30 days to just 1 day. And it's important to note that while reducing in-hospital evaluations, there was no increase in adverse events. It was non-inferior to scheduled visits. This is a brief graph demonstrating the drop in in-hospital visits, and you can see that the time to detecting arrhythmic events was reduced, and this obviously has vast clinical consequences on the patient. The ECOS trial came out in 2014. This also showed that remote monitoring was just as safe as scheduled visits. It also led to reduced shocks, which was mostly driven by inappropriate shocks, as well as reduced patient costs, which makes sense because the patients are coming to clinic less often. Unfortunately, it did not show a reduction in hospital costs. However, that may need more long-term studies. And then finally, this is a very important study. It was one of the few studies to actually show a mortality benefit. The InTime trial in 2014 also enrolled ICD patients, and it showed almost 50% reduction in mortality in patients enrolled in remote monitoring. It, however, did not show any change in heart failure admissions, but the mortality benefit in and of itself is a very important endpoint. Obviously, when you implement remote monitoring, there is responsibility on many levels. There is the patient's responsibility of making sure they set up the device and that they ensure follow-up. If they travel, they should take their transmitter with them, because otherwise it won't be transmitting information if they're not next to it. And obviously the caregiver has a responsibility, be it the physician or the allied health professional responsible for checking the transmissions. They need to check these in a timely manner, and anytime there is an alert event, it is up to them to communicate with the patient as soon as possible. And this has obviously been a concern for physicians who are about to implement this, because there are legal considerations and they need to make sure there is a setup, which is why a formal or informal agreement where expectations are set is discussed with the patient so that they know what to expect and there is a proper policy in place to address these concerns. And obviously the manufacturer has a responsibility in ensuring the entire system is intact. So obviously privacy is one of the patient's main rights. They have a right to have protected information, and with cybersecurity and cyber terrorism, there is a concern that somebody could access this information, and this is a possibility. However, the data is transmitted in encrypted form, and most manufacturers are very good at de-identifying the data. However, like I said, while that risk is exceedingly low, it is really necessary to ensure the highest levels of security so that there is no breach in that. Which brings us to safety. I don't know how many of you saw this show, but there was a show called Homeland that came out a few years ago, and I won't bore you with the plot, but essentially the vice president who has a pacemaker in one scene has his device hacked remotely, his heart rate is accelerated, and he dies. Obviously, patients did not enjoy watching that episode, and there was a concern whether they were at risk of this. So in case you haven't noticed, I haven't talked about remote programming. While the technology does exist, it has not yet been permitted, and this is obviously one of the concerns. However, studies have shown that it is possible, and if a patient does ask, we need to be open with them that it is a possibility. However, it hasn't been proven yet, it hasn't happened yet, and it requires a lot of expertise. If any of you had to interrogate a device, you realize that for a layman it would be very difficult for them to try to do something dangerous to a patient. However, obviously this is a concern. And another very important topic to touch on is reimbursement. It is much easier to place value on a face-to-face inpatient evaluation, but how do you reimburse a remote interrogation? It obviously does take time from the staff's day-to-day lives. However, it is harder to decide how much do you reimburse, and this has been a disincentive to the adoption of this clearly beneficial approach. However, despite that, some countries where reimbursement is not available continue to adopt it because of the resulting efficiency and their ability to schedule more patients. And this is a table showing that there is a lot of diversity in which countries will provide reimbursement for remote monitoring. The situation in Kuwait, unfortunately, it is not routinely available. We do have one provider or manufacturer that does allow us to participate in remote monitoring. However, those transceivers are only available at a cost, so we need to choose our patients, unfortunately. That being said, newer technology is coming into play where it eliminates the transceiver, and using Bluetooth, the device will connect to the patient's smartphone, which will in turn transmit the information. And almost everybody in this day and age has a smartphone capable of Bluetooth, and this will lead to more universal adoption, hopefully, of this technology. So the guidelines are a 1A recommendation to offer routine monitoring and try to implement it when feasible compared to the regular scheduled routine visits for all the obvious reasons I touched on. And a schematic illustrating that, once the patient is enrolled, you can see at the top, you have your inpatient visits, and at the bottom, the automatic transmissions. And the red asterisk is whenever an alert event is detected, this should trigger an inpatient evaluation to assess the patient, assess the device, and go from there. And just a quick example, this is a patient who I implanted a loop recorder in for syncope, and before coming here, I just wanted to make sure that everything was okay. So you log in, it's a pretty user-friendly interface. You can see your patients, when the devices were implanted, when their last transmission was, when the next one was, and you can see one of the patients hasn't really been participating in connectivity. So again, there is a responsibility on the patient's part. Clicking on the patient's last transmission, I get a brief interrogation report similar to what you get when you see the patient in clinic. I can see the battery life, the sensing, a real-time ECG of that patient or electrogram. In addition, it will tell me if any events have happened, and as you can see, no events since the last interrogation, no AFib, which is great. It took me a few minutes. I'm reassured that the patient's doing fine. So, in summary, there is no question that remote monitoring improves patient safety and outcomes. It is best thought of as complementary, but not a replacement to inpatient evaluations, which should still occur on an annual basis. It does, however, require policies in place, as well as semi-dedicated staff and patient education on what to expect and what the responsibilities are. And finally, it is very important that reimbursement strategies be put into place to ensure a more universal adoption on this clearly beneficial technology. Thank you.
Well, thank you very much for this really interesting talk. I've been making several notes during your talk. We're doing this since quite some years, and it brings a lot of issues. Any questions from the audience? Who of you have experience with remote monitoring? Can I see a show of hands? So not much, but it is coming. Yes, please. No, he had a question behind you.
Me? Okay.
Yeah, please.
Thank you, Doctor, for a very, very nice and illustrative lecture. Actually, wireless cardiology is getting a huge promotion. What do you think about its future in Middle East as far as not only the device wireless monitoring, but especially in huge population of patients with heart failure where physiological parameters can also be monitored, and especially in this financial scenario of the world which it is passing through? Thank you.
Thanks. No, I agree, absolutely. There is a lot of potential for this, and I know that the Middle East is slowly trying to implement it. With regards to heart failure, I didn't talk about it, but you have implantable hemodynamic monitors in the pulmonary artery, and those two have shown to improve heart failure outcomes with patients using similar technology. So we are definitely heading in that direction, and it will lead to more seamless patient communication and seeing everything. However, it does come at an added risk with cybersecurity and cyber terrorism. However, as long as we ensure that our security levels are at the utmost top standpoint, we can be reassured that the best patient care can be provided.
Yes, please.
Yeah, I'm Dr. Muhammad from Oman. Actually, I have two questions. First, if the patient is on the ICD and he developed VTAC, how I deal with the patient? And the other thing, the patient post-mortem, can I take this and put other patient? Because as you know, that's expensive.
Okay, so I'm not sure I understood. So the first question was, if a patient comes with VT and dialysis, does the patient have a device or? Okay.
And he developed VTAC.
Okay.
Shall I?
Was he treated by the device, or the device is not treating him?
No, he's on device already, and he developed attack of VTAC. Shall I leave him with his ICD and its work by itself, or shall I use
Okay. So that's obviously a very valid concern. Most devices are programmed not to shock immediately, but usually within a couple of seconds. If it's functioning appropriately, it will shock the patient. If, however, in front of you a patient is in a shockable rhythm and not being shocked by their device, then you are compelled to initiate resuscitative measures. Just ensure when you do cardivert a patient to keep at least 5 centimeters from the pads and the actual device to avoid any electromagnetic interference. And in terms of postpartum patients, obviously you need to assess the patient and see what their chances of recovery are if they are optimized, but they still should be considered as patients at risk, and you would have to go through the same guidelines you would go with as anybody else. It is not a contraindication. I don't know if that answers your question.
Can I take that news for the patient? The patient died already.
Oh, if a patient passed away. Okay, sorry, I heard postpartum. Okay, so if a patient passes away, there are places that will take devices and sterilize them and use them in other patients. However, I've only seen that in missions where they go from developed countries to developing countries and implant them for free. However, you do need to have a system where you sterilize those. But in developed countries, I don't think there is anything in play where you can do that. And unless you have a proper policy or procedure in place, you shouldn't be doing it, because if any infection or something happens, you're liable.
So, if time permits, I wrote down a couple of things, because we've been doing this for a couple of years, this thing, and there are a couple of issues that we encountered were as difficult. So one is the one that you showed. If you read these devices remotely, you will detect not so often ventricular tachycardias, as you pointed out, and even less shocks. So the ischemic cardiomyopathy seems to be more related with paroxysmal atrial fibrillation. You showed that also. And the question that comes up, how little atrial fibrillation, because now we can detect everything, how little atrial fibrillation is going to then imply anticoagulation in these patients? That's the first question where we got a real problem, that who do we anticoagulate and who do we not anticoagulate? So how do you deal with that?
Yeah, so that's a great question, because similar to MRIs and everything, we are in a situation of data overload, and we get all this information from patients, and it's hard for us to stratify it. Obviously, the knee-jerk reflex is you see a patient who has atrial fibrillation to anticoagulate them. However, there is really no data to support routine anticoagulation of patients who have AFib detected by their devices. And a few days ago, one of the speakers actually talked about how you need to confirm this by other methods, such as telemetry or a Holter, because most of the data is based on clinical AFib or AFib that is picked up by electrocardiograms. We do have data from loop recorders, but unfortunately from ICDs, we need more prospective trials. Essentially what I tend to do is, obviously the duration, if it's under 5 minutes and it's very less frequent, maybe you have more leeway. But if you have persistent AFib, or at least 24 hours, and the patient's chance of ASC is higher than 1, it's probably something you should discuss with the patient. I usually have an open book policy. I discuss it with the patient. We go over the risks. Obviously, you don't want to risk a stroke, and you just say, listen, the data hasn't really supported doing this routinely, but it's probably in your benefit to start this, and I feel as long as you adopt that approach, you're okay. But it's definitely a concern, because you worry you may over-anticoagulate patients with this strategy.
And the other thing that when you start such a program, you need to make really clear appointments with these patients, because the way it works with us is they download it via the phone, And in the beginning, they downloaded whenever they felt like downloading. So you will enter the situation that on Friday evening, somebody decides, I'm going to download this, and nobody looks at it until Monday morning. And certain things happen, like ventricular tachycardia, where you might have the patient want to come in for that. So here comes the liability factor also. So we have dealt with that, with making specific appointments when to download. There is then a response. But it is quite time-consuming, and you need to really put these appointments. Otherwise, you're going to get into situations. How do you deal with that? Do you do similar like what we do?
Absolutely. So like I said, unfortunately, it's not routinely available, but it should be clear to the patient that if there's an emergency, you should come to the emergency room. You know, similar to when a patient has your phone number and they assume it can just call you at any time. It's the same concept. They should know that this will allow us more prompt assessment. And as long as we set criteria that it will be checked within 1 to 2 business days, you set those, you should be covered liability-wise. However, there are ways to fine-tune these alerts, and usually any red alerts like VT, VFib, or lead abnormalities are tagged and sent immediately, and others are usually not and only come, there are different levels of alerts. So you can try to coordinate that so you only get the really important ones over the weekend. But obviously it is a concern, and you worry you may miss something and then you're held liable for it. So I think the most important thing is to implement a strategy and a policy and abide by it as much as possible.
And the last issue that you pointed at also is the reimbursement issue. That is a real important one, because it's difficult to get these things reimbursed because the patient don't physically come, and that's also something we've been struggling with.
Absolutely. And at the end of the day, we want to provide the best care to our patients, and we know this is the best care, and sometimes we skip the reimbursement just so we can provide the best care. But it is our right to demand some form of reimbursement because it is patient care, and it is reducing clinic visits and freeing up more clinic time. And hopefully that gets addressed in the future.
Well, thank you very much. I thoroughly enjoyed your lecture.
Thank you very much.
Great, thank you very much. All right, our next speaker is my co-chair, Professor Jerome Bax. And Professor Bax is the current ESC president and associate editor of European Heart Journal. He's a clinical professor of cardiology and director of non-invasive cardiac imaging at Leiden University. I've had the pleasure of working with him with GHA and ESC, and he'll be talking to us on imaging to select patients for TAVR. So we look forward to hearing that.
Well, thank you very much. And you asked me to speak about imaging and valve disease, but in 20 minutes that's very difficult to cover. So I decided to go for this, which is probably also in your countries becoming more and more of an issue. We in our center do significant amounts since many years transcatheter aortic valve replacements. We also do mitral clips, and we're starting with some more newer technologies, but the big two players that we have is transcatheter aortic valve and mitral clips. And when you do these procedures more and more, you start to see that you need certain checklists, and these checklists can be simple, and these checklists come from pre-imaging assessment. And so that is what I have put together, and what you see here is our experience that has grown over the years. So this is the slide that everybody always shows when we speak about valvular heart disease. When we're talking about an aging population, which is that we get witnessed with in our developing countries, is that we see that patients present with degenerative mitral regurgitation and severe aortic stenosis. So MR, AS are the two important ones. We also realize, and I was listening to Pepe Zamorano's talk, and we're also looking into that ourselves, is that the next stop, of course, is going to be tricuspid regurgitation. That is the third valve disease that's becoming quite important. We don't have much experience with that, but if you look at the statistics, there is a huge amount of patients with mitral regurgitation and aortic stenosis. We also know that the outcome of these patients is bad. If we don't do much, the outcome is not good, specifically with severe aortic stenosis, but also with degenerative mitral regurgitation, and specifically when the mitral regurgitation is secondary to LV dysfunction, the functional mitral regurgitation. And We can do things, we can do these procedures, but in these patients that we're talking about, they are also at high risk because they got lots of comorbidities, they often got reduced ejection fraction. When you start doing such a program of transcatheter aortic valve replacement, you will start to see in your clinics more and more discussions about patients with reduced ejection fraction. And you think to yourself, well, in the past we never had these discussions with the surgeon. And that is true because the patients with reduced or poor ejection fraction, they were never discussed because they were either not referred by the cardiologist for discussing about surgery, or they were denied by the surgeon to go on with surgery. But now with this transcatheter, it opens up for a different population, and that's one of the things that I will show you. So there's lots of valves at the moment, but the two most frequently used valves are the balloon expandable, as you see here on the left, and the self-expandable, as you see on the right. And each of them has its pros and cons. This is the checklist how we developed it when working with this. And I think if you systematically check for these things, you really carefully cover your patient. So what is important? The first thing that sounds a bit crazy is confirmation of aortic stenosis severity. But when we speak about patients with reduced ejection fraction, the question will come up, is this valve not opening because it's diseased and stenotic? Or is this valve not opening simply because the ventricle isn't pumping? And the second one is the procedural feasibility. That is mostly the aortic valve and the aortic root anatomy and dimensions, but it is also the peripheral vasculature, because we like to do these procedures through the peripheral vasculature and not transapical, because more and more it becomes clear that transapical approaches are associated with a worse outcome. We need to exclude contraindications, so that is important. And then we have a procedural approach selection, which is transfemoral, transsubclavian, transapical, or direct aortic. We also do significantly in Europe direct aortic procedures. So let's start with a case that you all know. 87-year-old man, ischemic cardiomyopathy, ejection fraction 30%, has a previous bypass surgery, has peripheral vascular disease, has COPD, has a kidney function with a GFR of 48, so modest reduced. He has a severe aortic stenosis. His symptoms are dyspnea, significant, and angina. Now, fortunately, you may say he has angina, because then we know at least it's a cardiac thing. Because a lot of these patients, as this one, also have concomitant COPD. And the question then often is this dyspnea secondary to his aortic valve, or is this dyspnea mostly related to his COPD? The other thing, and that is also an issue that we look into, is that if the patient have angina, you need to have an idea about the coronary artery disease. Does the patient need dilatation or bypass surgery? And we usually work that out in the beginning. They all have an angiogram, and then we decide which is the best strategy for the patient. So we assess in this patient the logistic euro score is 22%, is very high, and so he is discussed in the heart team. You see that every center that's doing these procedures have heart team discussions. That's where the surgeon, the anesthesiologist, the interventionalist, the heart failure specialist, the imaging specialist, they all come together and they discuss together these difficult cases. That's what we have implemented in our ESC guidelines quite some years ago. These are not patients that you just decide, let's do this procedure. You need to hear the pros and cons from all the players. So this is the echo of the patient. You see a no good function, and you see a valve that isn't opening, the valve that is thickened. So this patient has an aortic stenosis. Now we go to the first part, confirmation of aortic stenosis severity. So these are the simple criteria. Jet velocity more than 4, mean gradient over 40 to 50, mean gradient. Aortic valve area less than 1, and if you index that for body surface area, then it's less than 0.6. Severe aortic stenosis echocardiographic criteria. Estimation of the jet velocity, which then is translated into gradient, is simple. Assessing this jet velocity is also simple. This is a thing that you can easily get from echocardiography, and you don't make much mistakes, or there isn't much variation when you do it 2 or 3 times or when you have somebody else do it. That's important when you use echo, because some parts of echo are not so reproducible, and that's what we're going to come to. If we talk about the translation from a velocity to a gradient, is shown here. The max gradient is actually 4 times the velocity max square. That's easy to do. This is the relation between gradients and valve areas. I just put it there because sometimes, you see that we do not routinely work with that. So if your gradient is going up, as you see here, 45 to 70, then your valve area in parallel goes down 0.75, 0.6. It's always good to remember this. And in the area of 45 to 70 gradient and the 0.7, 0.6 area, that's where it gets interesting, and that's where we discuss, should we do something about this valve? How do we then echocardiographically take the next step and translate these into a valve area? And that you see here, you see in the formula there that the aortic valve area is the surface, and that is shown here. Let me see, I have the pointer here. The surface we get from the LVOT, and that goes in the equation here. So the VTI of the velocity before the LVOT, and the velocity through the valve, again, these are easy to assess. But this one here is difficult. This is a measurement, This is a measurement that is highly variable if you do it 2 or 3 times or somebody else does it after you. And this has the most implications in quantifying your aortic valve area. When we work with transcatheter aortic valves, we use more and more CT. We come to that in a second. But with the CT, we also learned that you can actually assess the valve area, as you see here, by CT, direct planimetry. We just measure it. And if you bring in that part of the CT, because you will have the CT anyway in these patients, if you bring that part into the equation, measuring your aortic valve area, so you replace the LVOT, which you derive from the echo, and put the CT in, then we saw in an article that we published 2 years ago that about 50% of the patients shift from a severe to a not severe, or from a not severe to a severe. And here is an example. You see here at the bottom the echo aortic valve area. When you calculate that, it comes to 0.58, which is severe. When I use the CT, and I call that the fusion aortic valve area, is now 0.8, which is not severe. You will see more and more that people will start using this integration between CT and echocardiography. Of course, if you have a transesophageal echo or you have an MRI such as this here, you can do a direct planimetry and then measure the aortic valve area. But in most of the cases you don't have, but you will always have a transthoracic echo plus a CT scan. Now comes in the discussion about low flow, low gradient. Difficult situation, aortic stenosis and heart failure. Valve is saying the valve doesn't open, but the gradient is not very high. So actually the question that you have, is this the valve that isn't opening, or is this the ventricle that is not pushing and therefore the valve doesn't open? I give you a case again. 73-year-old man, infralateral infarction, conservative treatment, has then angina, ejection fraction 20%. We do the angiogram there, 3 vessel disease, bypass and an ICD for the low ejection fraction and ischemic cardiomyopathy. We have then symptoms at the time of presentation, progressive dyspnea, so he doesn't have angina, New York class 3, comorbidities, severe kidney disease, and a logistic Euroscore, which is very, very high, 42%. This patient will never be operated. Here you see the information that you get from the echo. You see the echo is not functioning well. The valve is very difficult to see on this echo. That's also the reality. That's good to realize that you see. I can show you beautiful images, but the reality is often that you see those images in a lot of patients. And there we have the velocity. So you see here, if we calculate his ejection fraction less than 40%, the effective valve area is less than 1, so that means severe, but the gradient is only less than 30 to 40, so the gradient is not elevated, right? So the gradient says no, severe, and the valve area says yes, severe. And then again, the question is this the valve? Should the valve be replaced, or is the ventricle not working? Do we see that often? Yes, we see that in about 35% of the patients with severe aortic stenosis. And again, as I said in the introduction, we never looked at that because these patients with bad ventricular function, they were not even discussed with the surgeon. Or when they were discussed with the surgeon, they didn't pass the test. They were not accepted for surgery. So this is the algorithm that we have developed. This is low flow, low gradient, severe aortic stenosis. That's what we're talking about here. Valve area is less than 1 or index less than 0.6. The mean gradient is less than 40 and ejection fraction is less than 50. And you see there on top in black, classical low flow, low gradient. And what do we do in the routine? We do a low dose dobutamine challenge, and I'm going to show you that. And that's where we stop with this for the moment. We do the low-dose dobutamine, that's about 20 micrograms, and then we see what happens with the valve area and what happens with the gradient. I come back to this. But nowadays that we have the CT scan, you can also take the information from the CT scan, and that's probably much, much easier. I'll show you the results of our patient here. Here is the baseline, and you see the low-dose dobutamine, 20 mics. And you see that the mean gradient at base is 20, the aortic valve area is 0.6 index for body surface area. So that means yes, severe valve area, no severe gradient. When the dobutamine is then given, the gradient goes up to over 40 and the valve area remains the same. Now this is pleasant because that confirms that if I activate the ventricle, that the door, the valve, remains closed. So it must be a valvular disease. Let's go back to the algorithm in a second. We have, however, the CT scan in all these patients. And if you see on your CT scan this, and this is so easy to assess, everybody must agree that this is a severe aortic stenosis. This is not a pseudostenosis. So I believe that in the near future we will stop using this dobutamine because very often when you do it, it doesn't show anything. It doesn't make any change. And then you're stuck. So if you do that simple CT scan and you see the location of the calcium and the heavy calcium score, then you must know that this is severe aortic stenosis. Now I go back to the algorithm. So in the middle there, low-dose dobutamine, actually what happened is the gradient went up and the valve area stayed the same, so he has a true severe aortic stenosis. On the left, you see that the valve area goes up, the valve starts to open, the mean gradient stays low, so this is a ventricular problem. This is a pseudo-severe aortic stenosis. This is a ventricle problem, and this is not an aortic valve problem. But what happens in reality is the one on the right, where the valve area doesn't change and the mean gradient doesn't change, and we need something else. And I think that's where we're going to use more and more CT scan. Aortic valve anatomy and aortic annular sizing, that's what we're going to talk about now. We do that more and more from CT scan also, because on CT scan it's so easy to first evaluate, are we talking about a tricuspid valve, as you see on the left, or a bicuspid valve, as you see on the lower right. Of course, we cannot differentiate whether a bicuspid is a truly bicuspid, born a native bicuspid, or it's a degenerated severe aortic stenosis with fusion of the two commissures. And that is sometimes the difficulty. But the CT scan gives us much easier than echocardiography to determine whether this is tricuspid or bicuspid. We can also look at how much calcium there is. You see here in these different scans, and where is the location of the calcium. And the one on the lower right is very typical severe aortic stenosis. Importance of the calcifications that you get from the CT scan, that's also something we looked at. So if you do the scan before, as here on the top left, you see actually that there's lots of calcium in these leaflets. So what's going to happen when you implant the valve? As you see here the valve is implanted, that this calcium over there, that's the one that you saw before, sitting up there, that's going to stay there. And so that was going to result in the past in lots of paravalvular regurgitations. Based on the amount and location of calcium, you could almost predict what the problem was going to be. The answer of the valve companies is that they have developed these skirts which overlay and they prevent now the development of regurgitation. So this problem is basically solved. That means that we're not systematically repeating the CT after anymore, but before we did, to look at is there problems with the calcium and can we relate that or link that to the regurgitation. This is the most important thing that the non-invasive imager is asked to discuss with the transcatheter valve operator. You see here the CT scan, and we measure different things. We measure the diameters, short and long, we measure the perimeter, and we measure the area. Here you see the diameters. The mouse is not working really ideal. Here you see the diameters. We use a short one and a long one. And here you see the perimeter and the area. And those three parameters is what we measure on the CT scan. You can also do that on echo, as you see there. This is transesophageal three-dimensional echo, but it's more complex to do that than on a CT scan. When we then know these measurements, as you see here, the diameter, the area, and the perimeter, we put that in these algorithms, and then we can find which size of the valve we need. These tables are readily available. So you just measure those three, you put them in there, and you find the valve size that you need. Very important for the clinician is, if you undersize, you're going to end up with paravalvular leaks, but if you oversize, you take the risk of annular rupture. I believe that the risk of annular rupture is probably more important. Then we measure the aortic root dimensions, as you see here. We measure, number one here is the sinus of Valsalva. Number two here is the sinotubular junction. That's the transition between the root and the proximal aorta. And then we measure the ascending aorta. And these are the numbers that we use as sort of cutoffs, what we need to say if the patient is suited or not. What is very important in this whole discussion when you're going to implant a transcatheter valve, that if that valve comes in, that he's not going to obstruct your coronary arteries. So here you see from the CT scan the distance to the right, and here you see the distance to the left. And we believe that if that distance is very short, so probably less than 10 millimeters, that you take a risk of obstructing a coronary artery. Most people who have done these procedures have seen these things happening. The next step is then the access site. How are we going to approach this patient? So the access sites that we have are transfemoral, transapical, transsubclavian, and direct aortic. All of them are doable with the balloon valve, and the self-expandable valve is not good to do the transapical. Again, the CT. So you start to see now that the CT is crucial in this whole story. You do a routine echo as always, and on top of that you get the CT, and that's the imaging parts that you need. So from the CT, we now assess the central aorta, which I will show you in a second, and the peripheral vasculature. So we do that basically with the total body CT. So the femorals, aorta, root, and then the subclavians. Exercise, vascular or not, what is important from these vessels that you measure the diameter, you measure the tortuosity, you measure the stenosis, and you measure the calcifications. And that determines if this vasculature is good or not good for the procedure. And then if you have measured the diameters, as you see here, from the different arteries, you can match that again with valve size that can fit there. Vascular or not, you look at the central aorta. Again, there you also look for tortuosity, calcium, as you see here, porcelain aorta, which is not infrequent. If you come transfemoral and you touch with your catheter that calcium, it can go to the brain. So this is an absolute contraindication for coming transfemoral. And if it's not too dilated, because for the self-expandable, that is a contraindication. What we learned over time is that if you see here on the left, you have very tortuous vessels, then often there's not much calcium, as you see here in the gray picture. A lot of tortuosity and not much calcium. You also see here that if there is a lot of calcium, then there's often not much tortuosity. So we use these both scans next to each other, these post-processing, because it comes from one scan, and then you determine these things. We also assess the subclavians in one image so that we can see the subclavians. What we've learned from doing that is that the subclavians do not have much tortuosity, they don't have much calcifications, and when the femoral arteries are small, the subclavians are also small. And you got to think about Lima grafts. The last thing is, if you talk about the access site, transapical, you have two things to exclude. This is apical thrombus, and this is an apical aneurysm. So an apical aneurysm you can do with an MRI, with a CT scan, with an echo, any imaging technique. And a thrombus you can do with an echo technique, with an MRI, and also with a CT scan, as I've shown here. Here you see the thrombus sitting there. My lecture to you gives you the checklist of the things that you want to assess before you discuss the patient in the heart team, and that all comes from imaging. I believe in systematic evaluation before we go in these very difficult procedures. Thank you very much.
We'll take time for one burning question. It has to be burning. It's because we're a bit running short of time.
Dr. Abbas Sulaiman, Senior Consultant at the Heart Hospital. I have two quick questions about the valvular calcium score. Number one, there were differences in the studies about which areas actually of calcification you take into include the leaflets, the annulus, and the surrounding calcification in the aortic root. And the second question, the threshold. Some papers, give, as you said, 1,200 for the women and 1,600 or 2,000 for the men. As we saw in the most recent guidelines, I saw them they took much more than that, 3,000 and 2,000, very likely and then likely and those kind of things.
Yeah. So we take all the calcium in the valve, all the calcium that's in the valve. That's what we do in our center. The second one is, your second question is the issue about cutoffs, and I think that's the most difficult question. I personally have worked in a lot of different fields of cardiology, and whenever you use cutoffs, you will see that they don't hold up most of the time. What we determined from this study, you apply it in the practice and it doesn't work. And what about if your cutoff is 2,000 and your patient has 2,100 or 1,900? 1,900, is he then not an aortic stenosis? So I don't believe really in these cutoffs. So in our guidelines, we've put it as a supportive evidence. So you use your clinical judgment. So a 1,900, and it's very typical and characteristics, you just accept that as a severe stenosis. So I believe that that's the way you should use it. And we also have gradations in there. More than 3,000 is really always positive, less than that is not often positive, and then in the middle there's a gray zone. And I think that guideline has been composited very carefully so that we actually see and believe that you cannot use complete cutoffs. You need to use your clinical judgment as a doctor.
There was a burning question there. Was the last one.
I'm sorry that I took a bit longer, but it's such complex total material, and I tried to cover it little step by step so that you have a good take-home message at the end.
Thanks both for the nice presentation, Dr. Sheikh from Heart Hospital Fellow. I'm just regarding, you mentioned during the presentation that the CT might give more information, or we can get better information regarding the low flow, low gradient in terms of the, differentiating between true and pseudo stenosis, severe stenosis. So how do you explain that, although that with CT we will not change the flow, and the concept behind the dobutamine is that we will change the flow?
Well, the concept is really what we're measuring if the ventricle is diseased or if the valve is diseased. And so the flow is indeed important, but we're talking here about functional components and anatomical components. And the real question is not so much that flow issue, but the real question is this valve anatomically diseased? And so we use the flow as a surrogate for this anatomy. But the real question is this valve diseased? And that's an anatomical disease, resulting in functional consequences. So what we have, when we started to do more and more CT, when you read them systematically, you start to see that it's almost 100% match. When you see that, you cannot miss the severe aortic stenosis. It's sometimes difficult in the bicuspid valves, but in the tricuspids it's always very clear.
All right. Next speaker is Dr. Fahad Al-Kindi, and Dr. Fahad is a graduate of Sultan Qaboos University who did his internal medicine and cardiology training at Hamad Medical Corporation. He went on to Dalhousie to do his interventional cardiology, and currently is an assistant professor at Qatar University and Will Cornell University in Qatar. And it seems that one day his heart got broken. Inshallah, aduwak. We'll find out what happened that day. So, حياك الله Dr. Fahad.
Thank you, Professor Zubayd, for this coming. Good morning, everyone. I'm really glad that to present in this successful meeting. And they made it really hard for me to present after Professor Box, but we are happy that all those expertise are available here. So before I start, let me make it clear to everyone, because everyone is asking me about this attractive title, including the president of Gulf Heart Association, Dr. Khan. He just asked me about it. Actually, this is not my title. This is chosen by my great colleague, Dr. Awad Al-Qahtani, who put this title and my name on the scientific program, and I had no choice to change it. Okay. So my heart is still intact, although public speaking is one of the causes and triggers that can lead to the topic that I'm going to talk about. So my talk is about Takotsubo syndrome, and I believe this is one of the very interesting topics in cardiology, but unfortunately it did not get a fair attention from the medical community and from the cardiologists for quite a long time. And because of that, there is a very huge lack of knowledge in this topic, including the diagnosis, the pathophysiology, and even the management. So in this 20 minutes, I'll try to go through these items. So Takotsubo was first described by the Japanese doctor. His name is Sato. It was in 1991. And Takotsubo means tako means octopus, tsubo means butt. So it is named after the octopus butt that the Japanese fishermen were using at that time to trap the octopus. And the reason why he named it this way, because at that time, according to the literature, after the Japanese earthquake, there were a couple of patients that they came with acute coronary syndrome and heart failure, and they noticed that the heart looks like the Japanese, looks like the octopus butt, like in this photo. I don't have the pointer here, so in which the mid-ventricle and the distal portion of the ventricle, it is ballooning out, while the base, it's not, and that's why it was named as Takotsubo. And after that, many names have been given to the same syndrome, including broken heart syndrome, transient LV apical ballooning, stress-induced cardiomyopathy, neurogenic stent myocardium, ampulla cardiomyopathy. And in my opinion, it's good to give a name to something, but to give so many names, it makes it really hard. Even when you try to search about that disease, you will get lost in which name you will put. And also there are some names, I'm not sure how accurate it is, like a stress-induced cardiomyopathy, which is widely used, but now we know that there are some cases that are not related to stress. And also, is it really cardiomyopathy or not, because we are not sure if there is intrinsic muscle disease like the HOCM and dilated cardiomyopathy or not. So I prefer to use Takotsubo as it was first described. So for a long time, actually, people, they thought this is only limited to the Japanese people, ethnicity. And that's why it was ignored and nobody reported it from 1991, actually, as you can see in this graph, until 2000. So for more than 10 years, after the first case report, there was no case reports about this disease until another Japanese doctor who reported about 88 patients in 2001, and which was published in JAMA. And he reported those cases, and he called it apical ballooning without coronary stenosis. And that was the trigger for the US and Europe to start report cases. And from that time, from 2000, people, they start recognizing this entity very widely and reporting about it. So the question here regarding the prevalence, actually in most of the registries, they thought it's about 1 to 2% of all acute coronary syndrome comers. But the incidence, it's not really known. And I'm not sure who thinks that the incidence of this disease is underestimated. Hands up. Okay. So the majority, I think, is underestimated. Do you think there is a true increase of incidence? Okay, there are hands up as well. I think yes, there is underestimation of this entity. And the reason why, if you think about our practice, patients when he comes with the typical features of acute coronary syndrome or heart failure, and then he goes to the cath lab, coronaries are normal, patient is happy, physician is happy, then he will have an echo next day or the day after, and then there is no communication between the interventionist or the primary physician, and then the patient will be reported as dilated cardiomyopathy or low ejection fraction without mentioning that this is could be a Takotsubo, and that's why patients get lost. This is one thing. The other thing, there is a lot of cath lab now, they don't do LV angiogram with the availability of the echo, and this is another reason why I think it's underestimated. And apart from that, actually, there are other variants of Takotsubo that also they are not really reported. And this is from the registry, international registry of Takotsubo that enrolled around 1,700 patients. And they noticed that around 80% of those patients, they comes with a typical Takotsubo as we described. But there is other variants of Takotsubo in which the mid portion of the ventricle does not contract while the base and the apex contract. And also there is what is called the inverted Takotsubo, where the base is hypokinetic and the rest of the ventricle is hyperkinetic. This is one thing. And the other thing why I think it's also underestimated, because people, they think it's benign condition. And they think because of it's a full recovery, they don't give that too much attention to it. And actually it is not true. According to this registry, they found the mortality in 1 year can go up to 5.6% in patients with Takotsubo when they have complications. And actually there are other studies that they found that the mortality in Takotsubo can go hand to hand with a STEMI patient. So I don't think it's a benign condition. Why I think there is a true increase of incidence. Actually, the day before yesterday, Dr. Holper presented a very nice talk about the long working hours and the effect of long working hours on atrial fibrillation. And he said that if you work more than 55 hours per week, then that can increase the incidence of atrial fibrillation. And I think now we know the stress in Takotsubo is not just emotional. There is a physical stress which can trigger Takotsubo. If you work more than 55 hours per week, then this is enough physical stress that can lead also to Takotsubo syndrome itself. And I think we need to look at that. And I think probably the incidence will be higher than atrial fibrillation of Takotsubo because it is stress-related disease. So regarding the clinical presentation and diagnosis, I'm going to talk about it through one of the cases of my colleagues. So this is a 70-year-old female patient who presented with acute chest pain and mild shortness of breath after she learned that her son died. So you can see here in this ECG, there is ST elevation, slight ST elevation in AVR, and then ST elevation started from V2, V3 with biphasic T waves. So this patient had a positive troponin. So who will take this patient to the cath lab? Okay. I will do the same. So this patient came with a typical clinical picture of acute coronary syndrome, ECG changes, positive troponin. So we should consider this as a first differential is acute coronary syndrome and it should be taken to the cath lab. Hour later, this is the ECG changes that's seen in the same patient. You can see there is diffuse T inversion involving almost all leads. And there is also, if you look at the QT, the QT is prolonged. Okay. So just to say a little bit word about this ECG and the troponin level in patients with Takotsubo. So what they found, there is a good paper which was published in JACC by Masami. They tried to look at the difference in ECG between the patients with Takotsubo and patients with STEMI, and they noticed that there is what is called the switch of ST elevation between leads AVR and V1, in which in Takotsubo, like in our patient, the ST elevation will be more prominent in AVR as compared to the STEMI patient, where they had more prominent in V1. But this is not, they say this is not specific or sensitive. We should not take it as a diagnostic for Takotsubo. And the troponin level, you will find there is a big discrepancy between the troponin level and the segment that is hypokinetic. In Takotsubo, almost the whole ventricle, apart from the bases, is akinetic. So you expect to have a very high rise of troponin, which is not the case in most of the registry that found the troponin level does not really go that high. So this is another hint for you to differentiate. So these patients went to the cath lab. You can see here normal circ, normal RCA, no obstructive disease. And here this is the LAD. Who thinks that there is a significant disease there? Yeah, so there is a mid lesion there, which looks like a moderate. You might argue it could be a black rupture, but it looks by angiographically it's moderate. So this is the patient's echo. So you can see in the 4-chamber view, you can see there is akinetic apex and the hypokinetic mid portion and hyperkinetic basis. So in the echo, in a patient with Takotsubo, you have to look. Takotsubo is a disease that if you don't look for it, you don't find it. So you have to really keep it in mind to diagnose it. This is one thing. The other thing, you have to measure always the LVOT obstruction, because this is one of the complications that can happen. And also you have to look for a thrombus, because it's also one of the complications of Takotsubo. This is what we call the LV angiogram. So I'm not sure if it is clear to you, but what we're gonna see is the also the akinetic apex and mid and hyperkinetic pace of the ventricle. So this patient actually had a MRI because of that lesion in the mid LAD, which they thought maybe could be a black rupture. So MRI is very good test to differentiate between acute coronary syndrome and Takotsubo. So what you're going to see, basically, as you can see here, when you start from the base, you see this is the normal thickness of the wall of the base of the left ventricle, and when you go to the mid portion, you see the thickness start to increase, and you see the signal also is high. This is T2 MRI signals, high intense signals, which is very sensitive for edema, interstitial edema, which is characteristic in Takotsubo. Perfusion was done for this patient. There was no perfusion defect. And then the most important test, which is in MRI, is the delay enhancement of late gadolinium enhancement, that can also tell you if the patient has myocardial infarction or had Takotsubo. And in this patient, you can see clearly there is no delay enhancement. So this patient was diagnosed with Takotsubo. And this is his echo after 2 months, which is completely normal, recovered. So this is very interesting paper, which was, they studied about 256 patients with Takotsubo, and they look at their MRI, they look at their characteristic in MRI during admission and until 6 months. And actually what they found 81% of those patients, they have edema, and 0 patients, they have late gadolinium enhancement, which means that MRI is really very good test to diagnose Takotsubo syndrome. And the characteristic, this is from the international registry, which was done in 26 European country with US, and they found that 90% of the patient are female, and the average age is about 66, and around 75% they presented with chest pain. And what is surprising here as well, you will see 15.3% they have coronary artery disease, which I'm going to show you in the next slide why it is important. So it was until 2006 when the American Heart Association, they decided to incorporate this entity as a cardiomyopathy. And also the NCPI, they put it as a distinct clinical entity in 2008. And the first people who tried to put a criteria for this disease is the Mayo Clinic, in which they proposed a criteria in 2004, and then they modified it in 2008. And these are the criteria, which is Mayo Clinic criteria. So the first one is transient, hypokinetic, or akinetic, or dyskinetic left ventricle from mid-segment with or without apical involvement. And with stress trigger, they said it's often, but it is not always present. Absence of obstructive coronary artery disease or angiographic evidence of acute plaque rupture, new ECG changes including ST elevation or T inversions, absence of pheochromocytoma, and myocarditis. And actually, if you look at these criteria, there are 2 points here. If with the point number 2, absence of obstructive coronary artery disease, we know also that now there are cases of Takotsubo proven by MRI, and they have obstructive coronary artery disease. So I'm not sure this criteria should be there. And also the pheochromocytoma, there are hundreds of cases with pheochromocytoma-induced Takotsubo syndrome. And that's why other criteria was made, like John Hopkins and Goddard Bank and Italian criteria and the Japanese criteria. But the most updated criteria was by Heart Failure Association, which was in 2015. And what they did, actually they added, compared to the Mayo Clinic, they added the RV, myocardium, not only the LV, because the RV also can have a Takotsubo. This is one thing. They removed the pheochromocytoma, which was there in the Mayo Clinic, because pheochromocytoma can cause Takotsubo. And also they added other features of ECG, like the QT prolongation. So this is one of the papers that I recommend anyone interested in Takotsubo to read this paper. It was recommended by many people before me. And what they did in this paper, actually they divided Takotsubo into 2 categories, primary Takotsubo and secondary. Primary Takotsubo, which is acute cardiac symptoms, are the primary reason for the admission. Secondary Takotsubo can happen even if you get admitted for something else, like for a surgery, you might develop Takotsubo. Or pheochromocytoma, for example, then you get a Takotsubo. This is a secondary Takotsubo. So this is one of the interesting slides about the triggers. So we have an emotional triggers and we have a physical triggers of this syndrome. The emotional triggers, the most common one is the death of someone, relatives, or death, and or receiving a bad news like malignancy, divorce. These are well-known triggers. Severe argument, public speaking, and involvement of legal proceeding, financial loss, car accident. People who have a sudden car accident, they can have Takotsubo, and surprise party. And actually I have the next slide will be really interesting about this, and moving even to a new residence can induce that. The physical stress as well is well known now to cause a Takotsubo, especially after surgeries. And the most important thing in physical stress is dobutamine stress echo for our colleagues in echo. So this test can also induce Takotsubo. So this is the funny slide. And so what I did actually in October, before I know that I'm going to present this talk, I tweet about one of my patients during my fellowship in Canada, that this patient, she just learned that her son died and her heart failed. So I just mentioned, please be careful, be gentle with women. And you see all the the reply from the woman showing the sad face and crying and hearts and everything. And then last, when the Oman got the football cup, so I tweeted that even extreme joy can cause a broken heart. And I was attacked by all women after that, because none of them, they liked that. And they said, we don't believe in all these studies, and stop tweeting about this. Don't encourage guys to not making us happy and all these things. So what is the mechanism? What is the mechanism of this syndrome? Actually, there is a good study they found that they compare patients who have a STEMI with patients with Takotsubo, and they look at the epinephrine and norepinephrine level. And they found that the epinephrine and norepinephrine level in patients with Takotsubo is extremely high. It can go up to 5 times higher than STEMI. So it is catecholamine derived. And we know that emotional and physical stress can excite the limbic system, which will excite the presynaptic and the postsynaptic sympathetic neurons that will lead to release of norepinephrine and epinephrine. Epinephrine, we know that it will act on the beta blockers mainly, so it will cause hypercontraction. Norepinephrine acts on the alpha blockers, cause vasoconstriction and hypercontraction. And then what they mentioned that extreme rise of these hormones, they might lead to a negative actually inotropes instead of positive inotropes. That's what I was going to explain later on. Even in the animal models, what they did, they immobilized the rat. So when you make the rat immobilized, you stress them. So what they notice, when they do that, they do LV angiogram and ECG in those rats, they found that the rats, once you stress them by immobilization, their ventricle looks like the Takotsubo, it fails, the same shape. And also the ECG, if you can see here, there is ST elevation. Typical, like 50% of patients with Takotsubo, they have developed ST elevation. And more surprising, even one of the rats actually developed VF. And this is actually why those patients also have higher mortality, because they can run into arrhythmias. And the question is why some people, they ask why then the apex only failed, why the pace is hypercontracting while the mid and distal portion is not, it's failed. And the theory behind that, what they find in animal study as well, they found that there is gradients between the beta 2 receptors and the sympathetic activity between the mid portion to the base, in which the B2 receptors are higher in the apex, and the sympathetic activity is less, while here the sympathetic activity is high and the beta 2 receptor is less. And they found also that when the epinephrine level is extremely high, like in the catecholamine storm, there will be a negative inotropic due to switch from beta 2 adrenoreceptor GS protein signaling to which is positive to GI1 protein signaling, which is negative. That's why the effect will be negative. Regarding the pathophysiology, there are many theories. It's all theories. Nobody knows what's the exact theory behind it, but those are the theories which were proposed: acute multivessel spasm, coronary microvascular dysfunction, aborted MI, direct catecholamine toxicity. And I'll just give one slide for each. Regarding the multivessel spasm, actually the first case, which was published in 1991, he thought that it's because of multivessel spasm. And so something to support this theory is the one group, they did a study, they looked at patients with STEMI and Takotsubo as a control, and they found patient who has Takotsubo, they also have higher rate of migraine and rhinoid phenomena, which is, we know that it's a female predominant, and also there are theories that it's because of the spasm. And that's the thing with this theory, but in many studies done later on, they tried to induce spasm in those Takotsubo patients, but many of them they couldn't find any induction. Regarding the microvascular dysfunction, there are not much studies. There is one study from the Mayo Clinic here in which they tested the microvascular dysfunction In the cath lab, they gave a patient acetylcholine in different doses, and then they measured the flow, the blood flow response, and they found there is significant, actually, if this is the normal flow in the normal person, in the patient with Takotsubo, they have significant reduction of flow with acetylcholine. And also, another group, they look at the coronary flow reserve during dibutamine stress test, and that's actually what they found when they give high or low dose of dibutamine. There is difference in the flow reduction, but it wasn't that significant, but they recommend further study for that. The histopathology showed that the muscle toxicity, there is what is called contraction bands, which is suggestive of catecholamine toxicity, so it could be direct toxicity. Regarding the management, unfortunately, we don't have any randomized control trials for that regarding the treatment. And the probably part of it also, those patients always comes as acute coronary syndrome, treated as acute coronary syndrome, and they discovered only later on after they get the treatment. But the main objectives in this, you give a supportive treatment, you prevent complication, and you prevent recurrence. So the complication that might happen in this entity could be arrhythmias, could be pulmonary edema, cardiogenic shock, LVOT obstruction, and death. And actually death can go high up to 4%. So I've already mentioned about the mortality. This is another study here, we published in JACC. You can see in the red and green, the red one is Takotsubo and the green is STEMI. They carry the same mortality. Cardiogenic shock is about 10% in most of the registry. They can present with cardiogenic shock. And how you treat cardiogenic shock, the main thing you differentiate between treatment is the LVOT obstruction. If there is no LVOT obstruction that you treat like a heart failure, if he's in heart failure. If there is LVOT obstruction, then you need really to be careful with the fluid depletion and using the vasodilator. So you treat it like a hook. Beta blockers, no evidence. That is, although we are using it, but still we don't have any evidence that it show any benefit. Recurrence rate, it can go up to 5%. People, they get recurrence of Takotsubo. Which medication you should give to prevent recurrence? Still, most of the study did not show that beta blockers is helping. And ACE inhibitor, there are some data, they said ACE inhibitors might help. So this is before my conclusion. I was worried that preparing for such conferences will be also added as a trigger for Takotsubo. Our secretary, Madeleine, she did the most part of this conference. I really thank her here in front of everyone. And this is my conclusion here. Takotsubo syndrome is not a benign condition. We need a further study regarding this entity, further treatment studies also to prove the benefit, and we need our registry in the Middle East regarding Takotsubo. Thank you very much.
Well, thank you very much. And is there any one burning question we take? You, please.
It's me.
Thank you. Thank you, Dr. Fahad, for a great talk. And may Allah heal all broken hearts. We know that if Takotsubo is not stress-induced, it's at least a stress-related syndrome. But my question is, there is any association between the Takotsubo syndrome and conventional coronary artery disease risk factors, diabetes, hypertension, and so on? Thank you.
Thanks, Dr. Fadi, for the question. It's a great question, actually. There is one registry that studied around 1,000 patients of Takotsubo, and actually what they found there is very clear association between the conventional risk factors for coronary artery disease and Takotsubo. Those patients, they have higher prevalence of hypertension, reaching 40%. Dyslipidemia is very common in those patients. It reaches about 30 to 35%. And also smoking. So that's why they recommend, actually, if you have a patient with Takotsubo, although their coronaries is normal, you still need to check their lipids profile.
So we can do only that last question, very short and very short answer. I don't want to disappoint you, so please go.
Thank you, Fahad, for this elegant presentation. Just my question with regard the follow-up. We know that the stress is going on and with this stressful life that we have, so how frequent we should follow up this patient? And do we need a long-term follow-up like most of our cardiac patients?
That's a great question. Thanks, Dr. Rabadar. Actually, this is one of the areas that people they are looking at, because those patients usually they recover in 1 to 2 months. And regarding the follow-up, they concentrated mainly on stress management actually, because till now there's no studies have done regarding those patients to manage their stress. And I think this is the focus mainly, rather than cardiology follow-up. We need to refer them for stress management, because now we know that they are having more chance to have the recurrence. So it's in terms of follow-up, usually we follow up them until they recover, and there is no guidelines when do you need to follow them up later on. But I would suggest that these patients should be referred for stress management.
Thank you.
Well, thank you again very much for this great symposium, and thank you for your attention and staying, and hope to see you next year again.
Couple of announcements. I know we are running behind. There is lunch for the attendees outside and for the speaker moderators in the Dukhan hall. We're going to start back at 15 after 1. If you don't mind, you can come. We still have 2 exciting sessions, ischemic heart disease and heart failure. So we really appreciate if you can stay with us until the end. So 15 after 1, 15 minutes after, please.